Hello, everybody. Recording live from somewhere. This is Zach Couples with episode number 156 of the Movement Debrief. And today, folks, you're about to get your shift together because we're going to talk about all types of frontal plane problems like lateral pelvic tilt, if you got a shift in your back because you got some back trouble, or if you got Trendelenburg gait. Yes, folks, this and more is on docket for today. We're going to go into what it is, what's going on, and most importantly, what you're going to do about it so you can help yourself or your supreme clientele if they're having these problems. Because your boy, Big Z, has got a bunch of questions that have been asked by the people. They will be answered for the people by this people right here. Fam recognized fam. Without further ado, let's debrief, shall we? Can you do some videos on how to correct a lateral pelvic tilt with breathing techniques? Why, yes, I can. In fact, I'm going to do this video on it right now. So, what is a lateral pelvic tilt? That's probably the first question you should ask, and I'm glad you asked. If I may grab my son. A lateral pelvic tilt is essentially when your pelvis appears to be hiked higher on one side or the other. And it's also a movement that kind of sort of happens when you're walking. So if we walk and we have initial contact and then we land at mid-stance, there's going to be some changes in the shape of the pelvis that should happen when we are in the mid-stance portion of gait. And that's what a lateral pelvic tilt is. So it's normal, first off. It can potentially become problematic if it is associated with a reduction of movement options. And I also want to be clear, it's probably normal to some extent to have one side of your pelvis higher than the other. There are some structural changes that can happen within the pelvis, or not even changes, but normalities that occur within the pelvis that may make one side appear higher than the other. For example, it's very common for one innominate, one hemipelvis to be larger than the other. So if you have changes in the size of your hips, that can give the appearance that one is higher than the other. You can have differences in shapes on either side of the pelvis that can give that same appearance. So you're not going to change that. You can't change how you look on the inside. It's not like a thing to get, oh, well, I'm just going to get this side shaved down, so on and so forth. You don't do that. There's probably going to be some normal side-to-side differences, and we just have to reconcile that. That's okay. Just like you're not going to be upset if you're left-handed and you can't do anything right-handed, especially because lefties are better than righties. What you going to do about it? But just because we're not symmetrical with our hands, we also will not be symmetrical within our body. So just reconcile that. All that said, if you have this and it's associated with a reduction of movement options and it's limiting your ability to do X, Y, and Z, well, then you might want to spend some time learning from me because I'm going to tell you what to do about it. The first thing is we have to determine why does this tilt happen from a movement perspective and what direction is it going to go as a result of a loss of movement options, because that's what will happen. Here's what I want you to think about, a general concept. Your body is only going to move where there is space available. If you could envision that I got this squeegee bottle that's got a little bit of water, right? And I squeeze one part of the squeegee bottle. There's going to be less room available for there to go water where my hand is because I'm gripping that side. There's less available space. However, on the side that I'm not squeezing, there's a ton more space available on that side. And so more water can go there. This is how movement of water works. Folks, we operate under a similar mechanism. If I contract my biceps as hard as possible, which I do on the regular basis, because look at these bad boys. But if I contract my biceps as hard as possible, I essentially have the water bottle analogy happening here. Only this time, the squeeze is occurring on the anterior aspect of the joint. So I'm squeezing the anterior component of the joint. That's going to push synovial fluid posteriorly, and the fluid's got way more motion available there, and that allows me to flex my biceps freely. However, in this case, it's going to be really hard for me to extend my elbow, because in order for me to extend my elbow, I have to be able to push the fluid into the direction where I'm squeezing. And so there's going to be more freedom where there's more space available, in this case the posterior portion of the elbow. There's going to be less movement freedom available in the anterior portion of my elbow. Now, if you can visualize the squeegee bottle, if you can visualize my guns, please visualize them. Let's see how this applies now to a lateral pelvic tilt. When I perform a lateral pelvic tilt, that's associated with the mid-stance phase of Gait. And in mid-stance, you're going to see the pelvic outlets, the bottom portion of the pelvis, open up. And when the pelvic outlet opens up, there's more adduction, AD, and internal rotation available. Because when I open up the pelvic outlet, if I do that on the left side, you ready? You can see how the bottom portion of the pelvis gets closer to the femur. That's adduction. And when I posteriorly rotate the innominate, the acetabulum is going to point more inward, which is going to create internal rotation. Now, folks, if I have a lateral pelvic tilt one direction or the other, that means that your body is changing its orientation wherever there is internal rotation available. So, if I have a lateral pelvic tilt to the right, that's because there's more internal rotation available on the right side. If I have a lateral pelvic tilt to the left, that's because there's more internal rotation theoretically available on the left side. Now, the way that we get to each of those components is going to be different, because what underlies this, folks, is I'm not symmetrical side to side. I have changes in my internal organs that prevent me from getting to either of those positions the exact same way. Your heart is on your left, your liver is on your right. Based on some cool studies done in 06-07 Spine Journal, they show that based on this internal organ asymmetry, it is normal to have a rightward rotation about our spines. That makes it significantly harder for us to turn to the left. Again, that's normal. You cannot change that. Unless you get 2 hearts and 2 livers, I do not recommend doing that. Although, hey, if you're living in Vegas and you're partying hard on the Strip on the regular, 2 livers might be useful, but not from a movement perspective. So now let's go into how each of these lateral pelvic tilts would occur. Going to the right lateral pelvic tilt, so having the right hip a little bit higher, is easier to conceive because this movement strategy is very common based on some of the inherent asymmetries that we have in us. So in order for the right hip to be higher than the left, essentially what you have is some type of lateral shift to the right side, because it is normal based on some of the asymmetries that we have to have somewhat of a right turn through the sacrum. And so what will happen in that case is the right posterior outlet back here is going to have more movement available. It's going to be more open on that side, and that's going to allow me to shift my pelvis to the right. It's going to be more of a flat rotation to the right that allows that to happen. And there's some good videos by my dear mentor, Daddy-O Pops Bill Hartman, that go into the differences between how we get some of these rightward turns. I would definitely check him out. I'll link him in the show notes, which will be found on zachcouples.com/lateral-pelvic-tilt. But if the right hip is higher than the right, that is because I have a flatter turn that is turning me towards the right. That's normal. That is very common to happen. How do you know you have this? If you have someone who has a larger straight leg raise on the right in comparison to the left, that is a telltale sign that you're dealing with more of a flat turn towards the right. And in those cases, it's very common to have the right hip appear higher than the left. But I would not use visual inspection to determine that. If you look at the research on palpating landmarks to determine which hip is higher than the other hip, it's horrendously unreliable. I would use let movement be your guide. So if you got a straight leg raise that's higher on the right in comparison to left, chances are you're dealing with a flat turn to the right, and oftentimes that will be associated with the right hip higher than the left. Now, it's not as easy to elicit that same strategy on the left side. So if you see the left hip higher than the right, it's hard for me to turn my pelvis all the way to the left, and that's because of those inherent asymmetries that we have based on our internal anatomy. So I have to find a different way to make that happen. The strategy that will happen in that case, where the left hip will be higher than the right, is what we would call an oblique tilt of the pelvis, that way. So instead of having this flat turn where I can express my shifting into the right hip that allows me to raise my right hip higher than the left, this time I have almost a forward rotation, an upward rotation that is going into that position. And in this situation, that's where I can get the left hip appearing higher than the right. In order for that to happen, and this is the key difference between these two tilts, is based on the internal anatomy differences, it's harder for me to open up that left posterior outlet. Now, folks, it doesn't move that much, let's be clear, but tissues have to be able to become eccentric or become longer on that side in order to make that happen. The easier way to make that happen, because oftentimes I can't do that through the pelvic floor, is to anteriorly tilt the left side and then throw it over at an oblique angle towards the right. And that gives me the appearance of all this stuff on the back left stretched out. How do you know you got this? Well, folks, if the left straight leg raise is a lot more than the right, then you're probably dealing with something that's on a more oblique axis. Again, check out Bill Hartman because he's got some really good videos on this, and he does a really good job at delineating those two things. All right, let's just recap real quick, folks. If you got a right pelvic tilt, don't use visuals to guide you, but chances are the straight leg raise on the right's going to be larger. If you got a left lateral tilt, it is going to be associated with the left straight leg raise being larger, and you're going to get each of those in different ways because of the internal organ asymmetry. It's easier to get a right pelvic lateral pelvic tilt because that outlet is generally easier to open up. On the left, it's a little bit harder. So what you got to do is change the orientation of the pelvis to make it happen. Now, with each of these, what the heck do we do about it? Because, okay, I got all these crazy wild asymmetries. What's popping? What you going to do about it to get it mo better? Let's go into that next. Overarching both of these, a general rule of thumb is both of these lateral pelvic tilts will occur to make up for a deficit in internal rotation somewhere, because the lateral tilting that we normally should see happens in mid-stance of gait. Mid-stance of gait is associated with putting force into the ground and internal rotation. So you have to get IR back somehow. If my body can't do that by having relative motions happening within the pelvis, namely you can pick up all of the space available at each of the respective joints, you might change the positioning of your body to make that happen. An anterior tilt and not being able to posterior tilt is a way of picking up more internal rotation or changing the orientation of your body so you get more of it. If you have a harder time visualizing that, let me do the same thing with my thorax, folks. Let's suppose that I only have that amount of internal rotation, which is about 10 degrees, which I had my intern at Elevate Sports Performance and Healthcare measure me the other day, and that's actually about what I have. It was pretty disappointing. It's like, man, I do all this work and this is what I got? Yeah, I got big problems though, folks. So I got 10 degrees of IR. Watch me do a magic trick. I'm going to pick up some extra IR without really doing any exercises. Are you ready? Watch. Boom. Dang, you see that? I just got about 40 degrees of internal rotation. But what did I do? I slouched my body forward in order to make that happen. And I didn't get the internal rotation at the glenohumeral joint. All I did was change the orientation of my thorax by moving it more anterior, and that allowed me to get the appearance of having way more internal rotation than I actually have. If I apply that same concept to the pelvis and I anteriorly tilt or orient the pelvis, that's going to give me the appearance that I have more internal rotation available. It's going to pick up IR, but it's not internal rotation at the femoroacetabular joint. It's internal rotation that occurs because I've changed the position that the pelvis is in. And so, if you are seeing increased straight leg raise on either the left or the right, you could bet your bottom dollar that there's probably going to be some degree of an anterior tilt at the pelvis. So what you have to do is be able to teach your supreme clientele to bring it back, to go tuck themselves, to stack. So you have to be able to posteriorly tilt or orient the pelvis and then throw some breathing on the mix, so that way you can start restoring some of the relative motions that should happen at the sacroiliac joint. And if we want to be real about it, what it really is it's changing the relative tension that you can create at your pelvic floor, because that's what's creating these relative motions that should happen at the sacroiliac joint. And that's why stacking is important. I'm going to link a video in the show notes that will go into stacking. Again, zachcouples.com/lateral-pelvic-tilt. Check it out. So if you don't have that, this shifting stuff, folks, of restoring these lateral pelvic tilts is a moot point. You got to get that first. Once you've got the stack, all right, you've tucked, you've worked on full exhaling, you're able to get them into a position that allows for some of these rotational actions to occur, then you can work on correcting, or not correcting, but improving the movement capabilities with some of these lateral pelvic tilts. Let's first go into the right lateral pelvic tilt, because that's a little bit easier to see. Remember, right lateral pelvic tilt, they got more IR available on that right side, and they're turning at more of a flat turn to the right, and that's what creates the right hip appearing higher than the left. Basically, in that situation, what we gotta do is get them to turn the other way. And ways we can do that is by doing shifting of sorts to the left. And you ideally want to do so at about 90 degrees of hip flexion. And the reason why that is because, folks, if I have more of a straight leg raise on the right in comparison to the left, a straight leg raise is going to be associated with more internal rotation at the maximal amount. So any of your side-lying hip shift activities are going to be great for that. On the lower end side of things, if you're looking at what kind of things can I do on a training aspect, I might be doing some like Camporini deadlifts. Those are good. Any type of shifted RDLs, things like that are great. And then also doing split squats where the left foot is in front, the right foot is back. All of that can be really useful because that's teaching you to turn the pelvis to the left, and it's helping to increase the ability to open up the posterior outlet and the posterior part of the pelvis on the left side, because that can't happen when I have a right hip that is higher than the left. So you have to do things to improve IR on that particular side. If I have the situation where the left hip is looking higher than the right, which is associated with that oblique axis turn, in this case, I'm stretched out as all hell on the left posterior, so it's harder for me to generate tension on that side. So I have to do things that will push myself back the other direction. So in that case, because I'm really loaded on that right side, I can use that to my advantage to lever myself to push to back to the left. So in this situation, I like doing things like a side lying stride where you're creating some glute max activity to help shift you back to the left. You start with that. And then the other thing would be, now instead of doing the 90-degree hip shifts, once I've gotten that happen, I'm going to do more shifting activities in the 0 to 60 range, because that's going to help me get a little bit more external rotation back. So some of the standing, posterior hip stretches and things like that, those work really well after you've done some things that encourage right-sided activity. And those would be the steps that I would take to address each of these pelvic tilts. To summarize, if you have a right pelvic tilt or left, you have to stack first because both of those will have some type of anterior tilting of the pelvis occurring. If it's a right tilt, which is going to be associated with a right straight leg raise that is more than the left, you got to do things to open up the left side from an internal rotation perspective. 90-degree hip shifts, any type of RDL activity can work really well. If the left hip is higher than the right, that's associated with more of an oblique axis tilt. You're going to have a left straight leg raise that is more, so you probably need to get more ER-based stuff on the left side. The way you do that is first using the right side to push that person back to the left. So right hip extension-based activities work wonders there, and then you want to do shifts that are at more the 0 to 60 range to help restore external rotation. Folks, if you do that, man, you ain't going to be lateral pelvic tilting for much longer. Can you make a video about a lateral shift? Why, yes, I can. In fact, it's going to be the same video as the lateral pelvic tilt, folks, so let's get into it. First thing, what is a lateral shift? A lateral shift, if I can grab Ted to show us, is essentially when you have a functional, and I hate using that word, but a functional scoliosis that occurs due to some type of back issue. It can happen in acute low back pain. It's oftentimes associated with disc injuries, but again, not always. But essentially what will happen is that person will have the top half of their body shift one direction, and then the bottom half of their body will shift in the opposite direction, and it gives kind of this lateral side shift appearance. It can happen to either side of the injury, and it's very common in acute low back pain incidences. Now, before you go thinking, okay, well, I'm going to go do this, and this, first off, disclaimer, folks, get yourself checked out, because if you have any disc type injury, you're getting stuff going down your legs, you got weakness, foot drop, anything like that, you need to get evaluated by a doc to make sure you don't have anything drastically wrong, because that shift may actually be protective. If I devise some type of shift, it might help offloading the structures that have been affected, and especially if you're getting some symptoms that are undesirable, you may want to get that checked out and get it taken care of. Doesn't mean you got to go get surgery right away. Sometimes you might have to. But in some instances, doing some type of high-dose anti-inflammatory can be really helpful to reduce some of the acute inflammatory process, because what you don't want is nerve compromise with these things, because sometimes that can happen, especially if you're getting stuff going down the leg. So please get checked out if you got this. That being said, let's assume that, okay, you got checked out, things are hunky-dory, it doesn't seem like there's anything structurally wild and crazy. What the heck do you do about it? Well, first, we got to look at, from a movement perspective, what is likely going on here. And it actually ties back to the lateral pelvic tilt discussion that we just had. If I have any type of side bending activity happening, we have to look at, when does side bending happen from a gait perspective? And generally, more of this frontal planey kind of stuff occurs at mid-stance. Mid-stance is associated with internal rotation. If you got some type of lateral shift occurring, chances are that is the body changing its orientation to try to get into a position of internal rotation, or to offload an area that is internally rotating too much. We could look at it as either of those ways. And in fact, to illustrate this point, I'm going to walk you through a case that I had that presented with this particular deficit. So this person came to me, and I've seen him a couple times before. He's had on and off back pain. I'm just going to pull up his notes. And it was doing really well, but he took a swing of his club, and his back was a little iffy. And he presented to me with this cray-cray lateral shift. His thorax was going to the right, his pelvis was going to the left, and it took him a hot minute to get up. And normally, this particular individual presents with a loss of IR, range of motion. He's a narrow infrasternal angle, And it was very significant on the left in particular. His left straight leg raise was limited. So in this case, he was shifting his thorax away from that restriction. So limitation in straight leg raise associated with pain, which is very common with someone who has a lateral shift. If it was on the left and he shifts away, that's to reduce the internal rotation contribution on that left side. And so the straight leg raise was associated with pain, could not touch his toes, wasn't happening. Those were the big deficits. And so if we look at what I did to help him, most of my interventions were to try and find ways to get him to create internal rotation on that left side, but to do so by restoring relative motions at all the respective joints. And what I did was I did a manual technique where I got Ted on my shoulder. I took my hand, and so his right hip is on top, left hip is down low, and I started pushing the sacrum to the left. So that way he could load into the left side. He had about 60 degrees of hip flexion in this particular instance. So it's just to slowly get him to turn his body and start loading into that left side. So if we look at this from a gait perspective, if side bending occurs mid-stance, this sacral turn move that I did was more of an early stance-based intervention. So you have to get the early before you go into the mid. So I started with that first. From there, then I did a 90-degree hip shift passively. Just like I talked about with the active hip shift activity in the previous question, I just did a passive variation of this. So I had him lying on his right side this time. Femurs were out here. I pushed the femur back, pressed down. So that way, now we were starting to introduce a little bit more internal rotation. So I did those two moves, hung out for a little bit, and we saw what was crack-a-lackin'. After he got up with those two things, the shift was reduced, but it wasn't perfect, and he was feeling better. And I do want to preface in this particular case, he didn't have any symptoms going down the leg, so you don't always have to have discogenic symptoms with these particular presentations. Then, folks, I kept going. Now, we talked about only one component of this mid-stance, which is the pelvis essentially being able to shift or laterally tilt, in this case, to the left. But that's not the only thing that has to happen, folks. You also have to be able to get the thorax to tilt to the left. And so what I did in this case was I actually did some stuff to promote lateral expansion of the rib cage as well. And I did this on the right side because I needed him to open up that side. He was shifting and clamping down on the right. So I actually did things to open up that side. So I did some lateral expansion manually just because he was in an acute instance of low back pain. I didn't want him to do too many wild and crazy movements. He got up and the shift was almost completely gone. I was so pissed because I didn't take pictures of it because it was such a dramatic change for this guy. And he was feeling a lot better. And in all of those instances, all of those moves were to try and get the internal rotation strategy back that he was lacking. And then some of the activities that I gave him from a home perspective was to just do some, basically some passive ways of getting the same thing. I had him with a bolster underneath his left side. We did some stuff where I had him foam roller pushing into that left sacral turn. I had him doing some hip shifting activities in that particular instance. And he did those couple things and was feeling pretty good. So based on that, and based on what we know with what's going on movement-wise with the shift, the name of the game is getting internal rotation strategies back. And what's going to be your friend are two things. One, teaching these individuals to be able to shift their hips, likely towards wherever they're lacking. Use your measures to be your guide. If you have someone who's got a limitation in straight leg raise and a loss of IR, you're probably going to teach them to shift into that particular position. Not just at the pelvis, but also at the thorax. Anything you do that's going to create lateral expansion of the rib cage is going to be really useful. And if you can focus on those two qualities, a lot of times that can help reduce the shift And I've gone with that more so than any type of lateral shift corrections. And I've found similar results in efficacy. So the big key, if you see lateral shifts, is to teach those individuals to be able to restore internal rotation-based measures, assuming that they have the ER measures first, because you have to be able to get those before getting into the IR stages of things. And the reason why that is if we look at my wonderful cup of water that I have here, internal rotation occurs kind of in the middle of the cup. You got to be able to fill the bottom before you get to that side of things. If you do that, you ought to be less shifty. How would you tackle Trendelenburg gait? Whew. Well, I probably wouldn't tackle that person because you get sued, but I got some ideas about it, don't you worry. We first got to look at, well, what the heck is Trendelenburg gait? A Trendelenburg gait occurs when someone takes a step and they can't keep their hips level, the hips drop down. So normally during gait, the glute medians help keep the pelvis level as you're walking. And so if there's a situation where the glute med isn't working as well, which generally the two instances that happens is if there is some type of injury to the L5 nerve, because that innervates the glute med, that can lead to the Trendelenburg gait happening. That would be one instance. The other instance is a Trendelenburg gait is very common after a total hip replacement, especially if it's a posterior approach, which is why I absolutely detest the posterior total hip replacement. Folks, don't do that one. If you need a total hip, well, consult your physician, of course. I'm just some silly PT on the internet, but I would probably tell most of my Supreme clientele to try to either go with an anterior or a lateral. There could be some other approaches that are newer, but the posterior, because they cut through all the glute tissue, I hate it. So a lot of times though, with a posterior approach, they might cut the glute med on accident. And then now you don't have these muscles creating the stability to be able to keep the pelvis level. And that is kind of whack. So you might be dealing with those types of things. If you have any type of tissue interventions that can help those people, you might want to go with that. So, if there's some severe nerve compromise, you probably want to get that checked out. If, someone cut the glute med or they have a glute med tear, you might want to get that checked out and see if there's something that can be done about that. So once you've got all that squared away, though, what the heck can we do from a movement perspective? Again, we have to look at, well, when does that Trendelenburg gait happen? And also think about this, folks. When would it be useful? We don't think about like these compensatory strategies or these, undesirable biomechanical things that we may see as being useful. But really they are, because you can still walk with the Trendelenburg gait. A Trendelenburg gait, when the hip drops, that occurs at mid-stance. And in mid-stance, I have to be able to open up the pelvic outlet to some extent to create an adduction and internal rotation action. And guess what, folks? If I can do that, my pelvis can be level. If I can't do that and I ask that person, I say, hey person, I still need you to get into mid-stance. What you going to do about it? And they might be like, oh, well, snap. I don't really know how to create that opening action through the pelvic outlet because I can't ascend the anterior pelvic diaphragm. Oh, I got an idea. Here's what I'm going to do. I'm going to orient the pelvis as a unit just like that. Because now, instead of getting the relative motions to happen at the pelvis, well, heck, if I just droop the pelvis down like that, now I can adduct and internally rotate the pelvis, and life is good. Or is it? Well, Trendelenburg gait ain't going to have you walking all wild and cool, so we probably want to do things to see if we can restore that relative motion that is needed. Because what happened is, can't ascend the pelvic diaphragm, still got to adduct and internally rotate, boom, Trendelenburg, that's what happens. So for these folks, if you have a Trendelenburg gait, what could be useful, aside from stack, that's always going to be there, so please stack, check it out, is doing things where you can teach the anterior thoracic or the anterior pelvic diaphragm to ascend, which is going to open up the pelvic outlet. That's associated with restoring internal rotation. So you want to do things that are going to promote the internal rotation component of the gait cycle. You know, folks, like classically, before we kind of got into all the stuff that we're talking about right now, a lot of times people would do standing hip hike exercises to create some functional glute strength to help reduce the Trendelenburg sign. And now that I think about it, they were kind of in the right direction with that, but maybe not for the reasons that we thought. Because when I'm working some of those frontal plane exercises, well, folks, that's helping me do some of the stuff that needs to occur in mid-stance, namely ascend the pelvic diaphragm. So doing some of those hip hike activities, and in fact, the ones that I like would be like a right squat, left hip hike, where I'm squatting on the right leg and I hike that left side up. Well, crap, that could be a really good move for helping to restore the opening of the pelvic outlet that should occur in mid-stance. So anything that is in more the frontal plane side of things can be really useful in that sense. And those would be some of the big things that I would probably focus on. So the sideline stride exercise I talked about previously, that right hip hike activity, anything like that can be really good at getting these dynamics to occur. Also, too, if you can do stuff that helps promote more internal rotation, whether it's mid-depth squatting or anything like that, that can also be an excellent way to help increase the movement that should be occurring when it comes to the Trendelenburg gait. And so those would be the big things. Obviously, you want to make sure that you're getting any of the structural stuff checked out. That oftentimes happens with the Trendelenburg issue. But if you can do things that increase internal rotation, that's probably going to be really useful. I think that's a good stopping point for us today. I want to thank all of you beautiful, sexy people for tuning in. You've been incredible. Awesome questions. I appreciate your engagement. I appreciate you being there for the fam. Y'all are awesome. Keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving. And I'll see you next time. Deuces.